Good evening, everyone. Nice to see you all tonight. Thank you for coming out. It's my pleasure to be down here from Boston to present tonight the topic of health of the autonomic system and how this all interplays blood pressure, heart rate, and sleep, and how it impacts cognition and memory. So thank you all for coming tonight. I do want to start out by just addressing some questions that you may have. I get this quite a bit when I come up to the podium. People say, "She looks like she's 12 years old." So I'll tell you my secret right up front. It's oil of Olay. So without further ado, I have been here before down in your neck of the woods and very happy to be back. I was down here just about a year ago working with the UT Military Health Institute in our collaborative programming with our military center. I actually have a long military history. I was in the Army for 8 years, stationed at Fort Lewis up in Washington State. I was an Army neurologist in the military. They helped pay for my education, and I was very happy to serve. And I was down here a little bit earlier today doing a talk on women in leadership and talking about my military experience. So I don't know if we have any service members or family members of those who've been in the service, but thank you all for your service. And I appreciate talking with all of you tonight as well. So Dr. Seshadri found out I was coming down for the diversity talk and invited me to give this talk tonight and also a talk for the neurology department tomorrow. And one of the areas that I really love to study is the area of autonomic dysfunction. So we're going to talk a little bit about what it is and then get into some details about how this is affecting some of the things we do with our cognitive processing, how it affects our mind and bodies. We're going to talk a little bit about autonomic changes in Parkinson's disease and also in dementia. And then we're going to talk a little bit about the autonomic dysfunction as a marker for degenerative disorders and how we can actually impact it in our day-to-day activities. So when we think about the autonomic nervous system, you think about it in terms of things like fight or flight and rest and digest. So sometimes I like to use the analogy of watching the football game. I don't know if we have any football fans in the audience, but you know, when your team is playing and they're playing well and things like this, and you're eating your snacks that go along with the meal, you're kind of in rest and digest mode. And then when the other team scores or when the ref makes a bad call, then you're in fight or flight mode, and you can go from one to the other pretty quickly. So the nervous system is set up to try and optimize your functioning in each of those modes. So you need to be able to rest and be able to calm all your systems down to do things like digestion, et cetera. And then you also need to be able to be active when need be with certain types of stimulating situations to be able to act in those situations. And I listed here some of the neurotransmitters that are involved in these areas. So acetylcholine being one, and norepinephrine when we're thinking about fight or flight. And then when we're thinking about resting, acetylcholine. And the reason why I mention that is because acetylcholine is also the most important neurotransmitter that has to do with cognition, okay? So we see already early on that from the very basic level, having this neurochemical around acetylcholine is going to be very important in terms of how we function with those systems and then also with our cognitive system. Now, I like to use a lot of pictures, and you'll see that tonight in my presentation. And here I just want to show you there are two sides of our systems. So if you look on the left, you see the left side is the sympathetic system. Okay, here we go. This is all of our activation systems, right? So we see activation, contraction of blood vessels, stimulation of sweat production. We have stimulation of the heart in terms of increasing heartbeat, et cetera. And then over here on our rest and digest parasympathetic side, we have work on how our pupils function in terms of constriction, the airways relaxing, slowing of our heart rate, digestion, secretion of our enzymes in our gut, and then different types of bowel and bladder function are affected also by the autonomic system. So when we're functioning well, each of these sides are working properly, and then we have disruption in the system. Sometimes different portions can be affected, and sometimes the whole thing can be affected. Now, the control of this system is via pathways that go from the brain into the spinal cord, and then through the nervous system all the way out to those end organs. So it's a very, very complex system, the autonomic system. And any place where control is broken down, so in the brain, in the spinal cord, or in the periphery, those systems can be affected. So you can imagine then, for example, when somebody has a severe head injury, a traumatic brain injury, or they have a stroke, or they have a spinal cord injury, those systems can be affected, and those are very common sequelae. Autonomic sequelae are very common from those types of issues. So we're talking about things today in terms of movement disorders and in terms of dementia. And I want to show you a little bit more about these neurotransmitters I was mentioning before. So here is the rest and digest system. Acetylcholine is working here. And here is our fight and flight systems, acetylcholine and norepinephrine and epinephrine also. And so these are kind of activating enzymes as well. So there are a variety of disorders that have autonomic dysfunction associated with them. One of the big ones is Parkinson's disease. So patients with Parkinson's disease actually can have autonomic issues that start even before they start to develop their tremor. And some of those autonomic issues can be things like difficulty with their bowels, actually is a very early sign. So oftentimes patients with Parkinson's 5 to 10 years before they develop Parkinson's tremor might have difficulties with increasing constipation or significant changes in urinary frequency where they have a lot more frequency, a lot more urination issues at nighttime as well. We have a subset kind of Parkinsonism, so Parkinson patients who also have a lot more autonomic issues, and those individuals fit into a category of multiple system atrophy. Those individuals might have a lot of blood pressure fluctuations early on as well. And there's another subset of Parkinsonism called progressive supranuclear palsy, where people can have eye movement issues but also have autonomic changes. There's a type of dementia called Lewy body dementia where those individuals might also, in addition to memory troubles, have difficulty with visual hallucinations, for example, and a little bit of slowness and stiffness. And then Huntington's disease, you may have heard of as well, which is a movement disorder that can have associated memory difficulties, can also have autonomic changes. So this is what's happening in the brain in Parkinson's, and I use this as an illustrative case because a lot of the autonomic issues that are facing individuals with all of those disease processes can be understood by understanding what's happening with Parkinson's disease. So in Parkinson's disease, here we have a person, and if we took like a little bit of a picture through this part of the brain, this is the cut we would get. So these are the eyes, the front of the head, back of the head. These are the different temporal lobes that help control memory of the brain. And here is part of the brainstem called the midbrain. And in the midbrain, if you blow it up here, there's this part of the brain that's dark that has dopamine in it. It's called the substantia nigra. And then in patients with Parkinson's disease, there's a loss of that chemical. So with Parkinson's disease, the motor portion is a result of problems with the dopamine system, which is a different neurochemical. Patients with Parkinson's disease also have changes in the other chemicals of their brain. So they have changes in the acetylcholine, changes in the norepinephrine. So you're already thinking, cognition's going to be affected. Autonomic's going to be affected, because you guys know that from our previous slides. So you're already on to all of this, I can tell. Okay, so let's look at this in terms of the brain as a whole. So I mentioned before that in the early stages of Parkinson's in particular, people start to have difficulties with constipation. They also can have changes in their sleep. And one of the main issues with sleep in Parkinson's is something called REM behavior disorder. And what that is normally when we go to sleep, we have light stages of sleep, deeper, the deepest stages of sleep, and then we have our dreaming state, which is called REM sleep, rapid eye movement sleep, because our eyes are closed but going back and forth. Our body is paralyzed, and that's the time where we're dreaming, okay? Dreaming is very important in terms of overall body and mind health. The idea with dreaming is that we're kind of clearing up the different systems in the brain, kind of throwing away the trash, reorganizing the files, these types of things. And so in order for us to be thinking properly, we need to be able to get into all of those deep and restful stages of sleep and to be able to dream. In patients with Parkinson's disease, sometimes they can have difficulty where instead of being paralyzed while they're dreaming, they act out their dreams, either speaking or moving. So they might yell or they might punch or kick, depending on what they're dreaming about. Now, my patients talk to me about this if they're having, pleasant dreams, like walking along the lake or something like that. It doesn't seem to be too disturbing. But when they're practicing their boxing moves or working on their Tai Chi, sometimes it can affect their bed partner. So we have different types of things we can do to help to intervene. But this can be actually something that develops even before the motor functions, the tremor that we see with Parkinson's disease. And where that is a manifestation of some dysfunction here in the brainstem. And then as Parkinson's disease patients have more spread of the disease, then they can have difficulties with the basal portions of the brain, the motor control structures, and that's usually when the tremor happens. And then subsequently, they can have difficulties with changes in terms of the cortex, where they have problems with cognition. Memory difficulties can happen with Parkinson's as well. So there was a wonderful pathologist who looked at the brains of patients with Parkinson's disease in early, mid, and late stages and was able to define the changes, the pathologic changes that we can see with Parkinson's. And I'm going to show you one other thing. There's this pathognomonic aspect is a Lewy body, which we can see with Parkinson's and also with Lewy body dementia, that can accumulate in these various regions. And this is how we understand how Parkinson's evolves in the brain of an individual, okay? So this is helpful in many different ways. Number one, it helps us to understand how is the brain affected early? How do we stop it early and prevent the tremor down the line? Where does it come from in terms of does it start in the brain or is there some other part of the body affected? And how do we detect these early manifestations of autonomic dysfunction with cognition or with sleep difficulties or with blood pressure regulation, which also happens in this part of the body, to be able to identify individuals at risk that we can intervene on with different types of interventions such as viral therapies, stem cell treatments, different types of gene therapies, et cetera. So when we think about autonomic dysfunction, and we showed you the parasympathetic and the sympathetic, a lot of these things can be involved. So blood pressure can be involved. And so one of the problems with blood pressure with autonomic dysfunction is that it can fluctuate widely. And so people can have a normal blood pressure when they're sitting, and then they can stand up and their blood pressure can drop dramatically. And that can put them at risk for problems with blood flow to the brain, and put them at risk for things like falls, balance problems, thinking problems as well. We'll talk a little bit more about that as we move on. In addition, people can have changes in their limbs, so their hands and feet can be very cold if they're not getting good blood flow because of the autonomic system. They can have changes in their sweating, where they might not be sweating in their arms and their legs, but be sweating a lot in their chest and head area. They might have difficulties with dry eyes and mouth. They might have trouble with constipation or slowed movements in terms of their digestion. They might have difficulties with urinary frequency or urgency, sexual dysfunction, pupillary symptoms, which can contribute to blurred vision and poor night vision. And they also might have high blood pressure when they lay down flat at night. Now, I don't want all of you in the audience to worry and say, I have 7 of those things on the list. Because oftentimes these things can happen as we get older too, and they're not necessarily dysfunction. These are things that are symptoms and signs, and then with consultation with your physician, you can determine if it's out of range or if it's bothersome in terms of your daily life, okay? But these, when taken as a constellation in conjunction with some other diagnoses, can be useful in terms of determining underlying disorders and also with helping with management. So let's talk a little bit about blood pressure. Everybody knows that we don't want blood pressure to be too high. There's a lot of great information out about that, particularly in the cardiac literature and the stroke literature. Avoid high blood pressure, avoid high blood pressure. So we're very in tune to that. The issue is that low blood pressure is not good as well, too low. And what is too low? So a top number, if it's creeping down to the low hundreds or below 100, the top number and the bottom number we think about with blood pressure. The top number is called the systolic blood pressure. The bottom number is called the diastolic. So if that top number is starting to go down to the low hundreds or below 100, then individuals might not be getting good blood flow to the brain, particularly when they're standing, okay? And if we see a drop when somebody goes from sitting to standing, and that top number of 20 points or more, that's an indication that the system is out of regulation and we need to work to intervene. Now, people can have drops in blood pressure for a variety of different reasons. Somebody's dehydrated, somebody's been out sweating in the yard, doing their yard work for 4 hours on a sunny summer day in San Antonio. Somebody has a fever and they're sick. Those types of things can cause your blood pressure to act abnormally as well and to drop. But we don't want this to be a continuous process. We don't want it to necessarily be something that's outside of certain episodes. And when it is, if it's becoming more of a day-to-day problem, then we're worried about the autonomic system. So normally when we go from sitting to standing, what happens is the body senses a change in position and causes a constriction of the blood vessels in the legs so that blood pressure is maintained and cerebral perfusion or blood flow to the brain is continued, okay? So if the little vessels are not being properly stimulated, and they're stimulated by all those little nerves that I was mentioning before in the autonomic system, if those nerves are not telling those vessels to squeeze, they don't. Blood can pool in the legs instead of going to the abdominal organs or instead of going to the brain. And how does that manifest? That can manifest, as I mentioned before, with lightheadedness, dizziness when people go from sitting to standing, and there are a variety of other types of signs and symptoms we see as well. So, when we are worried about the autonomic nervous system, there are a variety of different things that we can do. We talk about it with our patients, so we get a good history. We'll do a physical examination, including blood pressure sitting and standing. And in our movement disorder clinic, everybody who comes into the clinic gets their blood pressure sitting and standing. Because in addition to underlying problems with the autonomic nervous system, there are medicines that can also drop blood pressure. So antihypertensives are medicines that are meant to drop blood pressure. And then some other types of medications that people take can also drop blood pressure. So we take a look at all of those things to see what can be impacting. And then in addition to that, we often have patients monitor blood pressure and heart rate at home with a home device, a little arm blood pressure cuff and heart rate monitor you can get for, $10 to $20 at CVS or Walgreens or whatever pharmacy you have locally. And if we're noticing that people are having abnormalities, we also might do something called a tilt table test, and that's what you see down here. Now, this does look like the bed that was used to make Frankenstein, but I assure you there's no pain that comes from this monitoring. So this is a type of test that's actually available at state-of-the-art medical centers, and typically it's either done in the cardiology department or the neurology department. And what this system does is it's able to monitor blood pressure and heart rate in different situations. So with deep breathing and with different positions, so we're able to assess whether or not a patient has underlying autonomic dysfunction. So this can be useful if there's a worry about autonomic dysfunction. It can also give us information about how severe the autonomic dysfunction is. Is it involving both the sympathetic and sympathetic systems? Is it involving the central and peripheral system? So we get a really detailed analysis from this testing about what could be going wrong, and being able to then trace it back to some underlying diagnosis if that is applicable. So we have done quite a bit of research in this area looking at blood pressure and how does it impact people. And so we know with Parkinson's patients, particularly with moderate to advanced stages, that 50% of those individuals can have orthostatic hypotension. So what does that mean? That means when we're monitoring their numbers, they're having that drop in the top number of 20 points or more, or a drop in the bottom number, the diastolic blood pressure of 10 points or more. Now, interestingly, you would think that if people had orthostatic hypotension or drop in blood pressure, they would feel it. But interestingly, only half of people who have this problem actually know that they have it and feel a symptom of lightheadedness. What else might they feel instead? Confusion when standing. So if they're standing up and somebody asks them a question, they might have trouble answering it. They might have trouble speaking when they're standing. They might have balance difficulties. And our patients who had orthostatic hypotension had an increase in difficulty with falls. And they also can complain of weakness in the legs in particular when they're standing. And so you might test their motor strength when they're sitting and they're 100% and they get up to try and move and they feel like their legs are heavy and they can't move. So these were some common complaints in individuals who had difficulties with drops in blood pressure. The other thing, in addition to confusion when standing, people who had orthostatic hypotension were more likely to have memory difficulties and more significant memory difficulties than those who did not have the blood pressure issues. Now, this was very interesting to us in terms of understanding some baseline risk factors for people with orthostatic hypotension and different things we had to monitor, but we also wanted to see if there was something that we could do about it to try and make it better. And so this is going to talk a little bit more about the impairments that we saw in terms of cognition in particular. So individuals who had orthostatic hypotension tended to have more trouble with memory impairment and more prolonged and severe memory issues. They also had difficulties with, in addition to memory, they often had difficulties with executive functioning, with attention. They sometimes had difficulty with their visual spatial functioning as well. And then in general, the other group that was affected were those that when they laid down, they had very high blood pressure. Those individuals could also have difficulties with cognitive dysfunction. So it's clear that normalization of blood pressure helps in terms of cognitive functioning. So then we looked a little bit at patients who didn't have Parkinson's disease in specifically, but also had atypical Parkinsonism. So this extended the group to involve those in some of the other categories who had multiple system atrophy, who had progressive supranuclear palsy, who had Lewy body dementia. And those individuals also had similar findings where if they had drops in blood pressure, they also had difficulties with cognition, with balance, and with falls. And so what we wanted to do then was work on increasing our routine screening of blood pressure in individuals who presented with any type of movement disorder or any type of cognitive difficulty. So this talks a little bit about dysautonomia, higher prevalence also in patients with stroke and cardiovascular mortality. So the individuals who had blood pressure fluctuations were also more at risk than later on with having stroke and other types of cardiac issues. And also an increase in fatigue as well. Those were some additional abnormalities that were seen in people who had autonomic dysfunction. So what do we do about this? Because we like to identify problems, but we really like to identify solutions. So we'll talk a little bit about some of these things. When we have somebody who has orthostatic hypotension, we try to have them avoid these types of issues. So we have them avoid dehydration. Standing motionless is another issue. So people who have autonomic dysfunction have a very hard time standing in line, particularly around the holiday season, waiting to, check out their goods at the end of the checkout lane. So standing motionless actually causes that venous pooling in the legs to happen to a more significant degree. So if somebody with orthostatic hypotension is identified, we have them move around instead of just standing still, even doing little leg lifts or moving their knees. And this was something that we did a lot in the military. You never stand with your knees locked at attention, right? You always bend your knees slightly and slightly move your feet and legs around. The same applies here for patients with orthostatic hypotension. In addition, you don't want to jump right out of bed in the morning because what happens is it turns out that blood pressure typically is lowest in the morning and then increases during the course of the day. So people who have lightheadedness, when they go from sitting to standing, it's typically worse in the morning. So that first time you get out of bed, either in the morning or in the middle of the night, you want to sit on the side of the bed for 20, 30 seconds before you pop up and start moving around. The other thing we have to avoid in people with autonomic dysfunction is vigorous exercise to the point where they're sweating profusely and then getting dehydrated. And hyperventilation can also make it difficult to stabilize the autonomic system. Hot baths, hot environment, if their sweating is off, it can cause these things to be worse. So we want to make sure that people have access to fans, cooling mist, air conditioning. Large meals. Now, why would that ever be a problem? Large meals can put a stress and strain on the autonomic system because what happens when you eat a large meal is you have a lot of blood that goes to your rest and digest system to work on digestion. And as a result, it can pull blood away from other areas. And so if your blood pressure is low already, you can be at risk for feeling a little faint or tired or weak after a big meal. So we have more frequent smaller meals in these individuals. Alcohol consumption can also drop blood pressure, so we typically make some recommendations in terms of how to utilize alcohol and how to, in terms of amount and time of day. When people are sick, such as with fever and such, that also stresses the autonomic system, so we want them to get medical attention early. Any type of straining, especially with bowel movements, so this can be a tricky situation because some of the patients are constipated, and then when they're having a strained bowel movement, it can drop their blood pressure. So what we try and do is optimize bowel movements to regulate people to having a bowel movement once a day. In addition to that, severe coughing spells that are prolonged can put a strain on the system as well. And then rapid ascent to high altitude. So people going on planes, typically we have them have a little bit more hydration, have a little bit of tomato juice, which helps to stabilize their blood pressure as well. Sometimes we have them wear compression stockings on the plane, and I'll talk a little bit about that as well, if we know that this is an underlying problem. And making sure that they, when they get to their destination, also continue to hydrate after that as well. So these are some of the conservative management techniques. So hydration, and we'll talk about how much and how to do that. Compression stockings, the compression stockings most of my patients wear go from the ankle to below the knee. And the reason for that is covering up the feet, some people like, but a lot of people end up getting more sweaty when they cover their feet. So we actually frequently use a brand called Zenza, Z-E-N-S-A-H, and these are what they look like. They come in fashion colors, so they can be coordinated to your shorts or other outfits. And my patients, one of their favorite things to do is to come in and tell me and show me their fancy compression stockings that are matching their outfits, especially around holiday season. So there's pumpkins and Easter bunnies and all kinds of things. The other thing is we don't want to just use water. Salts and electrolytes are important in terms of keeping the blood in the blood vessels, okay? So if we just use water, we're actually kind of flushing out our electrolytes a little bit, and we can end up with just having swollen legs rather than having optimized blood pressure. So we want to actually think about half of the fluid intake that we take is best to have as a little bit of electrolyte. So people are using things like Smart Water or a low-calorie Gatorade or a Propel or different types of powders that you can put in your drink to help with salts and electrolytes. And then we use physical maneuvers that raise the blood pressure as well if need be. So these are those outlined here. So I was talking a little bit about leg lifts, crossing the legs, sometimes bending over can be helpful, putting one leg up, down. I mean, this might be difficult in the middle of the mall, but you can think of these two might be feasible when you're waiting in line with the Christmas shopping, for example. Okay, so fluid. We talk a lot about hydration, and our goal for our individuals, who are 70 years and older, we often think about 40 to 60 ounces of fluid a day, okay? Now, that doesn't count coffee. That doesn't count tea that's caffeinated. But everything else counts, okay? So milk, juice, water, electrolytes. Now, I get groans and moans and all kinds of things. I mean, look at those goals versus the younger patients I have them do even more. So we can't complain too much. And the other thing is everybody's like, I'm going to be in the bathroom every 20 minutes. And that is true, but that's exercise, which is also very good for your autonomic system. Okay? So that's it's all wrapped up together. All right, so we talked about electrolyte-rich fluids. In some cases, when people have very low blood pressure, we have to add salt to the diet. I don't recommend you do that on your own without consulting a physician because that's something that has to be monitored closely if you have cardiac history, et cetera. We talked about compression stockings. There are also different types of abdominal binders, which are kind of like an elastic band that you can wear around the waist, which can be helpful with stabilizing blood pressure. Yeah, and some people, the different types of Spanx, girdles, all of those things can help stabilize blood pressure. So a lot of people wear those as well. They can be helpful if they're not too tight. And then there are actually medications, if need be, that we can put people on to help bring up their blood pressure and stabilize their blood pressure. And those are typically brought out once we've exhausted all the conservative therapies. So you don't have to read all of this, and it's very small print. But basically, what we decided to do is to work on treating blood pressure and seeing what effect it had on those issues we talked about, memory, balance, falls. And it turns out if we were able to get the top number above 80 and preferably above 100 when people were standing, all of those types of problems that we saw before got better, and some of them resolved completely. So especially if this is evaluated early on and managed early on, there is a significant ability to improve people's functioning in terms of their cognition and their balance if we are monitoring the autonomic system. So we are thrilled about this and really started working with our community about educating about autonomic dysfunction, blood pressure issues, and management strategies. And we've had great success, and our patients have done better long-term with their autonomic system problems related to Parkinson's, related to Lewy body dementia, et cetera, because of these interventions. So now what I'm going to do is I'm going to go into some more specific areas of the body. So we talked a little bit about blood pressure, and now you all have some strategies that you can use in your daily lives in terms of making sure your fluid status is optimized to stabilize your blood pressure, et cetera. Now I want to talk about some other areas. So one of the big areas is the GI system, okay, the gastrointestinal tract. So in individuals who have, for example, Parkinson's, Lewy body dementia, they can have difficulties with their gut so that they're not digesting properly and their motility is slowed down, so they might be very constipated. Now, what are the problems with that? Number one, when they're very constipated, they're having trouble with absorbing their fluids. They're having trouble with absorbing the nutrients from their foods, and they're having trouble absorbing the medications that they're taking. And so people who have constipation have less positive and potentially negative impact from those things that are coming in through their alimentary tract, through their mouth. So what we say to our patients is, if we have you hydrated, if we get the constipation under control, your medicines will work better. Your nutrients will be absorbed better, and you'll be at less risk for complications from the constipation overall. So we're very excited to work on these areas, and our patients see the dramatic benefits. They end up needing less medication over time when we work on the constipation piece. So sometimes our patients have trouble with their swallowing. This is the top of the GI tract, is their throat, and so they might have difficulties with swallowing. So how do we address that? People have evaluations with speech and swallow and do modified barium swallow studies where they have their swallowing evaluated under kind of X-ray so that we can see how things are going in terms of the swallowing. Are things going into the lungs? Are things going down properly? Is it delayed, et cetera? And in patients who have autonomic dysfunction, sometimes this can be impacted. They might have trouble swallowing their pills, choking on thin liquids, et cetera. We get them into the different therapies, and they can really make a big difference in terms of that aspect of things. So swallowing therapies, swallowing precautions. Sometimes we adjust their medicines to also help. Get their blood pressure stabilized can also be helpful as well. So sometimes we also need to modify how we eat. So with small sips of liquid after foods, maybe avoiding things that are crumbly or cause a lot of choking, like pretzels, crackers in certain individuals as well. And then sometimes we have to pre-medicate people with their Parkinson's before they take their medication, in terms of before they take their meals, to enable them to do a better job with that. And then different types of postures of their head when they're swallowing can be useful. So in a lot of patients with Parkinson's disease, they have 3 or fewer bowel movements a week. And our goal is to try and get everybody having a bowel movement every day. Okay, so we work on diet, we work on hydration, and typically our patients, when they're getting in 40 to 60 ounces of good fluids, we call them, a day, really see a big impact on their constipation. In addition to that, exercise is so important with constipation. So individuals who have a regular exercise routine, it can be as simple as walking, maybe it's biking on a stationary bicycle, maybe it's swimming, whatever the case may be, see an improvement in their constipation as well. And those individuals also have an improvement in their autonomic function, particularly any activities that involve the legs. So we are big proponents of the stationary bicycle, as I said, the swimming, sometimes the rowing machine. Things that improve the strength and innervation of the legs help with the autonomic system overall. So those are good exercises to do. So we talk about increasing fiber, exercise, I mentioned a little bit too, and sometimes we need to use things like stool softeners or osmotics if people are going beyond a few days in terms of their bowel movements to keep things optimized and to enable their medications to be absorbed properly. The other big area that we see people having issues with is the genitourinary area. So the bladder is very commonly affected. Number one, as we get older. Number two, with any type of neurodegenerative disorder, Parkinson's disease, dementias, et cetera. Most commonly, people complain of frequency of their urination. They feel like they have to run to the bathroom every 20 minutes. Maybe they don't even have to go, but they feel like they do. Some people actually feel like they have to go and they are making a lot of urine periodically. One of the things that we tend to do is we have them evaluated by our neurourologists, so experts in kind of the mind, spine, bladder connection. And there are different studies that can be done looking at the functioning of the bladder, so people can say, is it a hyperactive, is it an underactive, what the issue is, and then we can work on adjustments of medicines if needed, or scheduled voids. So this is something that we do with some of our patients where we just say, no matter what you're doing, every 2 hours you go to the bathroom. And that can really reduce difficulties in terms of the sensation of frequency in some people. The other frequent issue that we run into is something called nocturia, where people have to get up in the middle of the night many times to go to the bathroom. So as we get older, the expectation is most people probably will need to get up about 2 times in the middle of the night. Anything more than that can really have an impact on your sleep, which we talked about earlier. So we evaluate individuals and we do different types of things to manage that. Number one, we have people stop drinking their fluids typically around dinner time. So a lot of late night fluid intake can cause a lot of problems with nocturia in the night. And then we also adjust the timing of some of the medications that people take as well to try and make their fluids mobilize before they go to bed. So in the evening time, they should be mobilizing rather than in the middle of the night. And so some of those things have to do with how we mobilize our fluids, as I mentioned. So one of the things that we sometimes have patients do is in the evening while they're watching TV, we have them prop their legs up because oftentimes there's a lot of fluid that's accumulated in our legs as we're moving through the day. And so if we do that for a few hours and try and keep our legs above the level of our heart, oftentimes we're mobilizing our fluid then in the evening. And so then when we go to bed at night, that is not happening as much because we've already mobilized the fluid that's kind of third spaced in our legs. So let's talk a little bit more about sleep. So I mentioned before about REM behavior sleep disorder when we can act out our dreams in the night. The other things that people with Parkinson's disease and some of the dementias can experience are difficulties with insomnia. They can have difficulties with excessive daytime sleepiness. And one of the other frequent complaints that I didn't put on the slide is early morning awakening. A lot of my patients wake up at 3 or 4 in the morning and they're wide awake, ready to go, can't get back to sleep. And that's oftentimes something that we see with getting older, but also something that we see as well with some of the underlying neurodegenerative disorders in some cases. So we work on strategies around sleep hygiene first and foremost, and sleep hygiene is, this talks a little bit about sleep behavior disorder. Sleep hygiene is basically how we conform our environment or regulate our environment around sleep to optimize sleep. So we talk about things like having a set bedtime at night, making sure that the room that you're sleeping isn't being used for other things like watching TV and things like that. Going into the bedroom, having it dark and quiet, the right temperature, and that might be warm for some people, cool for others, and then having it quiet, trying not to have a lot of, moving parts on the bed, animals, other things like that. And then trying to keep it a quiet, relaxing place. That's also very important. We try and ban electronics from the bedroom and people who are having sleep disorders as well, because otherwise their phones might be buzzing and going off all night. So this is something that we work on in terms of REM sleep behavior disorder for our individuals who have those, so we can work with them on safety in the home and the environment, and then we can also work on medications. Usually we start with melatonin, which actually helps to kind of quiet down sleep a bit, and then we move on to some more potent medications if need be. This is actually a study that we did looking at sleep in Parkinson's disease. And what we found was that individuals who had sleep disorders were more likely to have a family history of Parkinson's disease and more likely to have earlier onset of the disease process. So it may be that the sleep aspect of the Parkinson's may be some type of genetic correlation as well. So we're trying to understand a little bit better about the genetics of some of these neurodegenerative processes to try and intervene as early as we can with therapeutic interventions. Okay, so overall, when we're thinking about management strategies for autonomic dysfunction, we want to monitor for signs and symptoms in our daily life. So for example, if you start noticing, I'm having trouble with getting lightheaded every time I stand up, or I feel like I have to go to the bathroom much more often than I used to in the middle of the night, or whatever the case may be, if there are issues with those, you can discuss those with your physician. They may recommend blood pressure, heart rate monitoring in different positions. Orthostatic evaluation means sitting and standing, or laying, sitting, and standing. They may recommend a neurological evaluation or a cardiac evaluation. You may have a tilt table test done, perhaps. And if autonomic dysfunction is present, we know that we can manage it in terms of our conservative therapies. We know that we can manage it in terms of changing our lifestyle with exercise and hydration. We know that we also have some medication options that can be utilized, either adjusting the medicines that we're on now or adding new medicines if need be to help optimize our functioning, help reduce the risk of memory trouble, difficulties with balance, falls, and fatigue if those are present related to autonomic dysfunction. So these are the different things that we went through today, just a summary. And I want to open it now up for all of you for your questions. Thank you for your attention.